Ladies and gentlemen, welcome to the college lecture. And I have the pleasure of calling Professor Priyanga Ranasinghe for the college lecture organized by Ceylon College of Physicians on personalized medicine, NHS, to clinical practice in Sri Lanka. Professor Priyanga Ranasinghe, MBBS, MD, PhD, is a professor in pharmacology attached to the Department of Pharmacology, Faculty of Medicine, University of Colombo, since 2012, having obtained MD Clinical Medicine from PGM in 2018. He is the first board-certified specialist in clinical pharmacology and therapeutics in Sri Lanka. In addition, he also has completed a doctoral degree in research in 2018. He is also a clinical fellow of the University of Edinburgh, UK. His research interests are in clinical pharmacology, hypertension, and pharmacogenomics, and he has published over 150 papers in peer-reviewed index journals and has had H-index of 49 with over 19,500 citations to date. He has received over 20 awards for research, including consecutive Presidential Research Awards since 2011 and the VC's Award for Research in 2022 from University of Colombo. In addition, he has been ranked among the world's top 2% scientists in 2021 and 2022. Over to you, Professor Priyanga.
Thank you very much, sir, for the kind introduction. Thank you to the college for inviting me to deliver this talk. So what I will be talking about today is kind of a novel topic, a little beyond what we currently practice, but something that will be very relevant, especially in the future. So this is what I hope to, during the next 25 minutes or so, this is what I hope to discuss, introduce certain topics, and then discuss about the current practices in relation to pharmacogenomics and personalized medicines in the UK, and also where we stand in the Sri Lankan context and the way forwards in personalized medicine. Now, a fair warning at the very beginning, one of the challenges in delivering any genetics talk is that people tend to get lost in the different variants and the numbers and so on. So what I would sort of advise to you at the beginning is don't get lost in the variants and whatever I present. I will tell you about the clinical relevance and the medicines that are related. So we'll keep it simple and I'll try to explain as we go along. So as we know, we all deal with patients who present to us with the same diagnosis, whether it is diabetes or whether it's a cancer or whether it's something else. It's always patients are coming with the same kind of diagnosis at the end of the day. But from clinical experience, we know that from the cocktail of medicines that we have available, even though they use it as prescribed, whether they are adherent or not all of them respond in the same manner. You have patients who do not respond at all to medicines, even though they take them properly. You have patients who develop adverse effects of medicines when you prescribe them on the standard doses that are recommended. And then, of course, you have the third group who reasonably responds well. So variability in drug response is one of the challenges we face when managing patients who present to us with the same diagnosis. That's because at the end of the day, we deal with a common cocktail of medicines. And if you talk about the data that is available, variability can be, as I said, in two aspects. Variability can be in terms of the efficacy or whatever the clinical outcomes that we get. Variability can be in relation to the safety of the medicine. And available data suggests that about 90% of the drugs that we have only work for about 30 to 50% of patients. Now, if you take a patient who is diagnosed with depression and started on a medicine, we do give them a certain period of time to respond. And it may be the case that from the beginning, that medicine was not the right choice for that patient. not on the clinical diagnosis, but as I will highlight to you, based on other parameters that may not have been the right choice for that patient. But we have to still wait for a certain period of time before switching them on to a different medicine, which may or may not work. So with this, probably then patients may go on for weeks or months without receiving appropriate treatment. Then in terms of safety, I think Shobana also spoke about this during her presentation. This is from meta-analysis all over the world, has shown that about 6.5% of all admissions are due to adverse drug reactions. Some of them preventable, some may be not. So this variation in clinical response at the end of the day stems from a lot of factors. Of course, we are here assuming that patients use the medicines as prescribed. We are taking adherence out, but then there are other factors that affect the variation in response, and the disease status, the physiology, and so many things. And one of the things that have come to light of late, this is not a new concept, but one thing that has been appreciated world over is that the genetic factors, the genetic makeup of individuals and populations influence how people respond to the different medicines and whether or not they get adverse effects due to these medicines. So with this, the term pharmacogenomics or pharmacogenetics has come to light. What this term essentially means is that it is the study of the different variants in the DNA or the RNA that characterizes the response to medicines. Friedrich Vogel is the person who coined this term. Pharmacogenomics, genetics, both the words are used interchangeably. And from that stems what we call personalized medicines, where essentially, now this is what we have, where we have the current medicine, and we use, I think a previous speaker also spoke about this, where one medicine or one treatment fits all. And as I have highlighted, that is not the case. There are so many other factors that influence this. And personalized medicines is about giving the right patient the right treatment based on understanding the genetic factors that influence that decision making. And as I will highlight to you during this talk, these are things that are already being implemented in countries like the UK and the USA, where certain medicines are targeted, and I will highlight some common examples that are relevant to us. How common is it? This is again data from the West and the Middle East. At least, so you can see over 90% of people in their genome carry at least one actionable variant. One actionable means if that variant is present, the dose or the medicine should be changed. Now, from that data of the people in the audience here, I can tell you each one of you is likely to have up to 4 variants, actionable variants that modify your response or the chance of getting adverse effects to medicines. So with that in mind, we will see, first of all, what is the current practice with regards to genomics and personalized medicines, taking few examples from the UK before we move on to the Sri Lankan context. I will basically take 2 examples of genes, variants and 2 medicines, and then look at an implementation trial and also the difficulties and challenges they have identified in the UK. First of all, the Dip.ICT gene. Now, 5-fluorouracil and the related medicines are medicines that are commonly used in chemotherapy for cancer. And one of the common adverse effects that we see are things related to GI, the bone marrow suppression, and the skin. Now, this particular medicine is metabolized and inactivated by the dihydropyrimidine dehydrogenase, which is the important catabolic pathway. Now, this Dip.ICT gene is highly polymorphic. And the polymorphism of the Dip.ICT gene influences how this medicine is metabolized. So obviously, if there is a polymorphism resulting in loss of function or reduced function, that means when we give the standard doses, the metabolism in that patient is reduced, which means the higher concentration will be present in the blood, which means the higher the chance of some of these toxicities. Now, in the UK, the prevalence of these variants is about 1 to 2% from the data in the UK. And they have implemented the 4 polymorphisms that they have found in the UK population. They have implemented genetic testing before commencement. And evidence has shown that this has led to a reduction in the adverse reaction. And at the moment, about 40,000 tests are being done in the UK. But then again, even in the UK, things are challenging. Getting clinicians on board has been challenging, as I will highlight to you with another example. But keep in mind, I have highlighted the word European. And as I will show to you subsequently, the polymorphisms that are there in the European populations will not be the polymorphisms that we have. Europeans and South Asians are quite distinct, as I will show you in a diagram. So it is important, one of the key things, the challenges that we will face is we need to understand the variants that are present in our population to study them. Then the second example I will take is again another gene, CYP2C19, but leave the gene aside for a moment. It is related to something the previous speaker spoke about, clopidogrel, antiplatelet drug. Now, this particular medicine is converted to an active metabolite by metabolism with enzymes related to CYP2C19. And obviously, if there is a polymorphism in the gene that leads to inactivity of this enzyme, then the drug will not be active and you will not get the desired clinical outcome. So if you are given it for secondary prophylaxis, then although the patient may be adherent to the medicines, you will understand they will not get the clinical effect. They may end up with a stroke or get a recurrent MI or whatever. They will not get the desired clinical outcome. And the CYP2 clinical trials have shown that this genetic polymorphism, start evaluating for this genetic polymorphism and choosing maybe if the loss function is lost, choosing an alternative therapy can influence the clinical outcome. And at the moment, pharmacogenomic testing for these variants are done in the UK and recommended from NICE quite recently for the stroke indication. Although they have found evidence even for myocardial infarction, getting the cardiologist and all on board for this testing has been a bit of a challenge even in the NHS. But what I would like to highlight to you, ladies and gentlemen, is that according to this study published in the Pharmacogenomics Journal, quite a relatively old publication, 2015, this particular variant, although the UK is implementing, if you can see number 11 and number 12, are East Asian and South Asian populations. So this particular variant that leads to loss of function are more commoner in our populations. For example, it is said that about 13 to 14% of South Asians have alleles that lead to loss of function. So then we can expect a significant proportion of our patients getting clopidogrel will not get the desired benefit. So then it will be good to consider whether we will talk about cost later. Would it be really cost effective to test for this variant before giving the medicine? Something to ponder on. But as I said, so the UK now, so understanding and appreciating variants present in your population is the first step to this. Then moving ahead, it is about implementation. And I will highlight to you this with an example of a study done in UK about how they have implemented this practice. There was a study called PREPARE trial, which was run during the COVID pandemic, which is preemptive pharmacogenomic testing for the prevention of adverse drug reactions. So it was a multi-center study that was conducted all across Europe, including the UK, where it was each site was randomized either to start with pharmacogenomic-led prescribing, which meant the people going into the study got their pharmacogenomic profile done in relation to certain variants, and the prescriber had that data available to them to decide on treatment. And then that was compared to standard care. And what they implemented is what is called panel testing. Panel testing is basically you have a panel that screens for these 12 genes and 44 variants in a single panel, and which is affecting 39 medicines. Now, again, I'm highlighting to you the variants that are included in this panel would have been variants that are relevant to the European population. So it's quite interesting what they have done. From that, they produced this, what is called the pharmacogenomics card. This card was given to the patient. When they go to the prescriber, they give this card and the QR code is scanned into the app. And in the app, as you can see, the prescriber can see the variants and the medicines that you have to be careful when prescribing and the recommendations in that particular patient. So the patient has the genetic profile in hand, and the prescriber has access to that information when prescribing to decide on the medicines. And what did they see? What was the results of this study? Then this study, of course, included about 7,000 patients in total. The results were published recently in Lancet, and what they saw is that of the patients who had actionable pharmacogenomic variants, using genomics-led prescribing led to a 30% reduction in the adverse drug reactions. So even in the UK, now, as I highlighted before, they are moving on from studying their variants to what are called implementation. I highlighted to you 2 examples. But even there, things have been challenging. I will just highlight to you some numbers from this particular publication, which it is a scoping review, which has looked at how much of genomic programs are implemented worldwide. I talk about 2 examples, the Dip.ICT in the UK, the clopidogrel in the NICE, again, the CYP2C19 gene. How much of programs are currently under implementation and where? So they identified 40 distinct programs, 95% of which are from high-income countries and 66% are from the USA, right? So even in developed countries, implementing these has been challenging. One classic example is in relation to carbamazepine. This is from East Asian countries where they study the HLA gene and the skin toxicity. The governments of Singapore, they actually introduced this testing for carbamazepine sponsored by the government. And what they saw is that the clinicians, rather than testing and starting medicines, move away from the medicine and started selecting different medicines, which in turn, although led to a reduction in carbamazepine-induced skin toxicity, they still got the skin toxicity due to the other medicines. So they didn't see an overall reduction in skin toxicity, although that induced by carbamazepine got reduced. So getting the clinicians on board has been challenging everywhere. There's this interesting document, if you have time, this is freely available to download, about personalized prescribing. This is published jointly by the College of Physicians in UK and the BPS, British Pharmacological Society. And it highlights to you their future plans and the challenges that they have faced in the UK in the introduction of personalized medicines. Right, so let us now move on from the context of UK to the Sri Lankan context. Where do we stand in personalized medicines? I suppose this is personalized medicines in the good old Sri Lanka, where the right people get the right medicine. But we have done certain things, although we have not implemented personalized medicines in Sri Lanka. There are certain things that have been done, but there are certain challenges we face. One of the important things to appreciate is that we need to describe the polymorphisms in our population to implement. And according to this study that has been published, our population is quite distinct from other those of European ancestry. Now you can look at these diagrams, and if you look at the bottom right-hand corner one, you can see these are different populations. One of the clusters is the South Asian population of the variants, but you can see that the other populations are quite different. We as South Asians, whether it is Sri Lankan, Indian, Pakistani, we tend to cluster together as South Asians. Even within the country, although few minor variations exist, different ethnicities cluster together. Tamils, Muslims, all cluster together. But we are different from other populations. So implementing variants that have been found in UK will not be possible for us. We need to understand variants that are present in our population. I will highlight to you this with 3 examples from the Sri Lankan context. Common examples of medicines that we use. Number 1 is statin. We all know what a fantastic medicine statin is. It's used for a lot of indications, primary prevention, secondary prevention, and I'm not going into clinical details at the but we know that there are certain people, when given the standard doses of statins, they experience adverse effects and toxicity. Could this be related to genomics? And what I have heard from clinicians is that from their personal experience, that they see our people do tend to respond to lower doses of statins rather than you do not require higher doses. Is there a genetic basis behind this? Let's have a look. So there's a study that we did, which is published in the Pharmacogenomics journal. We looked at the variants that are responsible for the efficacy and toxicity of statins in our population. This is, of course, not a clinical correlation study. This was a retrospective analysis of an available database just to understand the occurrence of these variants. Again, don't worry too much about the different genes. So these are the genes that we looked at. I will only highlight to you 2 examples. For those of who are interested, there's a website called PharmGKB, freely accessible source. It's done by an international consortium on genomics that nicely lists all of the medicines and the FDA recommendations on pharmacogenomics. It's quite a useful guideline. And it breaks down the evidence to level 1, level 2, level 3, and level 4. Level 1 being the highest, where actions are required if that variant is present. Just for information. So what did we find? We found these particular variants, the SLCO1B1 gene, star5 variant to be there in 18%, CYP2C9 star3 variant to be in 10%. So what does that mean? This, the SLCO1B1 encodes a transporter that takes up statin into the hepatic cells. This particular variant that is present in our population is a no-function variant. So what will happen? This transporter will be either not there or reduced function. So then that means uptake to the liver, the site of action will not be there, but the serum concentration will be high. The higher the serum concentration, the higher the exposure of the muscle to the statins, and then the likelihood of myotoxicity when used standing doses. That is number 1. And then, so this is the diagram. So how do we compare? This is a comparison of our population with others. So we have a higher presence of this variant compared to East Asians, the Americans. We are more or less closer to Europeans, Finnish descent, but non-Finnish Europeans, we have a higher occurrence of this variant. Then the CYP2C9 star3 variant, it encodes a metabolizing enzyme. Again, the star3 variant is designated no function, right? That results in reduced statin metabolism. So again, when we use the standard doses, higher levels will be there in the presence of these variants. So how do we compare with the other population? That there's a significant difference where, especially in the European population and other population, it's about 3 to 6%, but in our population, it's about 10%, right? So there's a higher occurrence of this particular variant. So this means when our people get the standard doses, the clinical implications are that the dose requirement may be less. And if we use the higher, especially in high intensity therapy, if we use the higher doses, they might get adverse effects due to that, which then leads to reduction in adherence and so on. I will take another common example. This is again coming from our work from the same data, where we looked at pharmacogenomic variants affecting the warfarin, the efficacy and toxicity of warfarin. I will highlight this to you taking one particular gene, the two genes, the VKORC1 and the CYP2C9, right? This is how much these variants are there in our populations, right? And how does this relate to the action and the toxicity of warfarin? So this is where it relates to. The VKORC1 is an enzyme that is involved in the activity of warfarin, the warfarin cycle, that is, sorry, vitamin K cycle, and it is inactivated by the warfarin. And so then this activity, the higher or lower the VKORC1, that can impact the activity of warfarin. Then CYP4F2 gene is involved in metabolizing vitamin K, and higher the lower the activity of that particular gene can influence the vitamin K availability in the population. So what did we see in our population in comparison to others? So the VKORC1 with the particular RSID, sorry, and it is an increased function variant, right? So that means there will be higher dosage of warfarin required because of the increased function. There will be higher availability of this enzyme in that person. So then a higher dose of warfarin will be required to inhibit the activity to get the INR to the desired level. And you can see that the occurrence of this particular variant is higher in our population when compared to others. Similarly, the CYP4F2 again encodes an enzyme that is involved in metabolizing vitamin K. The particular variant that we studied in our population is designated the decreased function variant, which means the metabolism of vitamin K is reduced and more vitamin K is available. Again, that means to inhibit its activity, we will need a higher dose of warfarin. And you can see that this particular variant, the presence in our population is very much higher than what you would expect, what you have seen in other populations. So we need to think about carefully. We always derive our clinical practice from guidelines coming from European countries, where dosing recommendations are based on European populations. But are they really right? A fit for our South Asian population is something that we need to carefully think about. There are many other examples. I will not go into detail in the interest of time. DPYD I highlighted for anti-cancer. There's a variant called XRCC1, again in our population. It is significantly lower than in others. The presence of this particular variant actually increases the activity of the drug. But I will not go into detail. So then our population, when using the standard doses of platinum-based compounds, will require higher doses because this particular variant is less in our population. This particular variant is related to DNA repair. So again, our population is different, as you can see, right? So there are numerous examples. I will not go into details, but which highlights to us that antidepressants, immunologicals, even the anti-cancer, the paper will be published quite soon. And things related immunologicals, right? Methotrexate, rituximab, there are variants in our population which we are looking at, and the data will be published soon. But there are so many examples where which shows that our people respond differently to these medicines because of the presence of variants. However, implementation is challenging. Number one, as I said, we cannot implement based on variants that have been found in European populations because we are distinct. So we need local information. If we are to have a panel like that has been done in that European study, we need to have a panel that incorporates our variants. So that needs to be found out. We need, like what we are doing today, we need to raise awareness. So back in the days in the medical school, this is not something we heard about pharmacogenomics and so on. Starting from medical school days to going to clinicians, we need to raise awareness about this, and education and training is an important thing. And the third thing is obviously we need to improve access to cost-effective pharmacogenomic testing. And genomic testing is becoming less and less costlier by the day, and the availability is also increasing. Even in Sri Lanka, there are places available which you can do, including the Faculty of Medicine. So in summary, as I have shown to you taking examples, genetic factors are important in the treatment decision-making process. At the moment, as clinicians, when making decisions, we have certain information available to us in addition to the clinical parameters, in addition to the socio-demographics. We have biochemical tests in our decision-making, not the diagnostic tests. Things like the renal function and things are available to us for the decision-making process. So my question is, in the future, having the pharmacogenomic information available to us will help us in this decision-making process and help us in leading to what is called personalized prescribing that is relevant to that patient. But implementing is quite slow, especially in developing countries like ours. So with that, I'd like to end the talk. Thank you very much.
Thank you very much, Professor Priyanga Ranasinghe, for this excellent lecture delivered and eye-opener for most of us who now we were blindly following the European guidelines. Sometimes we find that atorvastatin 40 is too much, but we wonder whether we should reduce it to 10. And thank you very much.